Welcome back to the Breakthrough Medicine Conference. I'm your host, Dr. Laurie Bouchard. Joining me right now, we have Dr. Breanne Kallonen, who is an author and CEO of the Metabolic Reset Program. I'm so excited to have her here today because she's going to dive deep into all about the stool testing and comprehensive analysis of what you can tell for complex diseases. So welcome, Dr. Breanne.
Thanks, Dr. Laurie, for the introduction, and welcome everybody to today's presentation on complex cases and the clinical applications of the GIMAP stool test. For those of you who don't know me, my name is Dr. Breanne Kallonen. I'm a naturopathic doctor, but most importantly to me, I am a mom of two. I have two private practices in Saskatchewan and Ontario. I'm an Amazon best-selling author and international speaker, as well as a business and clinical consultant for functional medicine practitioners. And before we dive into the complex cases and we go through the case studies and identify how important stool testing is for patient care, I wanted to start off today's presentation with a story with regards to how I got using the GIMAP in my clinical practice. So I'm originally from Ontario, and I started my secondary practice in a province that I'd never been to, in a very small town called Kindersley, Saskatchewan. This is about 2 hours outside of Saskatoon, and it is a very small town. And when I first started seeing my patients here, I noticed some very big difference in what they were coming to see me with versus in Ontario. In Kindersley, Saskatchewan, I had significant GI complaints in my practice, everything from consistent, profuse, watery diarrhea to bloody diarrhea. And this was a very big difference from what I was typically treating in Ontario, which is more so IBS type symptoms or those who had IBD, but were previously diagnosed and managed. And I thought, whoa, why are you coming to see me with bloody diarrhea? So I thought, okay, we got to do something. We have to figure out a way to test these patients. And that's where I stumbled upon the GIMAP test. And from this testing, what we found is a lot of these patients had a similar infection with a pathogen, either enterotoxigenic E. coli or enterohemorrhagic E. coli. And we were able to trace back the source of this infection in this town as well. So I'm very grateful for this test for being able to pick that up, because I feel like we've made a really big difference in the town and the people that live there. One of the things that I want to start off this presentation with is the questions with, do you use lab testing in your practice? And when I speak to practitioners, often what I'm hearing is that patients are having a hard time justifying the costs of these functional medicine tests. And what I want to say to that is patients aren't afraid to invest money, but they're afraid to waste their money. So if you can get really educated on this test and be able to explain it to patients in a way that they can understand the value and understand how this is going to be important for their overall health and their treatment plan, it really can make a big difference. And when we perform the right test, we are able to uncover the hidden causes of a patient's symptom. And this allows us to get more pieces to the puzzle for each patient. So I'm a really big fan of root cause resolution, test, don't guess. Why do I like the GIMAP? Well, number one, it's a single sample collection. So this really improves patient compliance. They just have to do one sample. My kids, when they've done this test, we've always joked that you just poop in a French fry container. It's very easy to do. I also love this test because the panel reveals not only the microbial targets like the bacteria, viruses, parasites, worms, but also quantifies it. So you can actually see the exact number of bacteria, parasites, etc. that are there. It doesn't just report positive or negative, it actually tells you how many. It's very sensitive, very specific, and it has intestinal health markers, which I really like. So we're going to go through what those are and why they're so important. These intestinal health markers can really help us uncover the why something was able to grow and thrive in the first place. In addition, it shows virulence factors for H. pylori. If you don't know what that is, we're going to go through it. Same with the antibiotic resistant genes. So you can really say to a patient, the quadruple therapy or the conventional therapy for H. pylori, hey, it may not be effective for you because you do have these antibiotic resistant genes, or maybe they don't. The typical problems with culture insensitivity is they may not catch anaerobic bacteria. That's the bacteria that cannot live without oxygen. Those are really hard to grow with culture insensitivity. And those make up a really large part of the gut microbiome. So we don't want to miss those. Many microbes can grow or decay after collection or in transit. And some organisms don't actually grow in the culture condition. So with culture, you really have to choose the appropriate agar and the appropriate sugars, etc. And you might not actually be able to grow some of the organisms that we want to test for, and they're completely missed. How to read results. So one thing to keep in mind with the GI map is you have to be really careful in how you read the results. The number that comes after the E is really important. So the E means 10 to the power of. So for instance, 3.5 to the power of 7 is actually 35 million. So you have to move that decimal place 7 times to the right. So the number that comes after the E, the larger that number, the bigger the number is. Who to test? Almost every single patient in my practice, I'm recommending the GI map to. Not only for individuals who have GI symptoms like bloating, gas, diarrhea, constipation, but also those who have stress, because we know how important the connection between the brain and the gut is. Those with autoimmunity, we're going to go through a couple autoimmune cases, fatigue, nutrient deficiencies, all of that can impact, your gut. Are you absorbing the nutrients from the foods you eat? Are you absorbing your supplements? Metabolic disorders, I treat a lot of weight loss resistance and I do a lot of stool testing for that. Metabolic concerns, the gut is really center and impacts the entire rest of the body. Here is a list of targets that the GI map looks at. Now we're not going to go through line by line what each and every one of these mean. If you're interested in learning more about that, I do have a training course which will walk you through what all of these mean, and we're going to link that at the end. But what we're going to do today is I'm going to highlight some of the keynotes, some of the things that I wish I had known when I started running this test and started my practice, as well as we're going to go through some unique complex cases that I really want to highlight in each of these sections. So the pathogens. A couple ones that I really want to target here are salmonella, because salmonella can trigger autoimmune diseases of the joints and connective tissues. So you really want to get a good patient history if someone's coming in with an autoimmune condition. Do you have a past history, or do you remember having food poisoning prior to the onset of your symptoms? In addition, because I'm treating a lot of weight loss resistance, I'm always keeping an eye out for Yersinia. This is linked to autoimmune thyroid disease, both Hashimoto's and Graves'. Typically, when you run a GI map, those on the pathogen sections typically are below detectable limits. That's what less than DL means. Many of these ones are acute and short-lived, and the patient will have significant symptoms. Typically, those are not what they're coming to a naturopathic doctor or functional medicine doctor with, but of course, like my patients in Kindersley, it's always possible. Really important for this section in terms of treatment, you always want to research the antibiotic resistance with each type of infection. Antibiotics may not be indicated in all of these pathogenic infections. You want to consider the source of infection. Where is it coming from? If you can identify the source, then you can prevent reinfections. Like I said, some antibiotics with some pathogens are actually contraindicated, so you want to keep an eye out for that. And you want to look at intestinal health markers for insights. So for instance, secretory IgA is a marker of immune function. If secretory IgA is high and the patient has one of these pathogens, that's showing that the immune system is recognizing it and working to clear it. In my opinion, in looking at the patient history, this might be more of an issue if the immune system was really low. Then we know we might need to support the body in clearing this. You might want to consider broad-based antimicrobials like GI Micro X. I use a lot of that in my practice for pathogens and SIBO and opportunistic overgrowth. Oil of oregano is a great broad spectrum antimicrobial. Silver Pure is fantastic for bacteria, viruses, parasites, and we'll go through some of these in more detail as we go through the presentation. Here's a list of antimicrobials I typically consider in my practice. I'm also using a lot of berberine. I love that herb. Tribulus is an interesting one. We typically think that for, hormonal-based concerns, but we do know that Tribulus has some antibacterial and antiviral effects, and because it's not used often, I do find it works particularly well. Antibacterial info to consider. When you're using antimicrobials, what you might want to inform your patient of is the potential for side effects. Often in my practice, I see diarrhea or headaches, especially those with the gram-negative bacteria because of that LPS toxin release. I inform my patients that this typically can last 3 to 5 days. You may want to increase binders. Perhaps you just have some increased fiber in their diets. Add in some greens powder. Some practitioners will use colostrum or charcoal, might be things to consider. Typically for high levels on the GI map or chronic infections, I'm treating for 4 to 6 weeks or until symptoms resolve. And those lower, more acute infections or preventable, I'm doing more of a 5 days on or 10 days on, 5 days off, and just continuing until the cycle repeats. H. pylori. H. pylori, here's what you can see when you test for it on the GI map. H. pylori in this case, the result is below the normal range. If this is what you're seeing and the patient doesn't have symptoms, typically I am not treating here. If the patient has symptoms and the number is above the normal range and that patient has these virulence factors, I'm definitely treating. Now, these virulence factors are one of the things that makes the GI map really valuable for you because it can tell you the virulence of the particular strain of H. pylori that the patient has. So how likely is it to create issues for the patient? So for instance, some virulence factors will increase the risk of ulcers. Some will increase the risk of things like inflammation in the small intestine, gastric ulcers, peptic ulcers. Some of these virulence factors require longer treatment. For instance, the BAB-A, you will have to increase your treatment plan for a longer duration because that virulence factor makes it a little bit more tricky to treat. Now remember, with H. pylori, 50% of the population are estimated to be carriers, and there's no need to treat it. Also, you see here is the antibiotic resistance genes that the GI map reports. So this can give you a good indication if the quadruple therapy would be effective for the patient based off of, is the particular strain resistant to those antibiotics or not? Again, asymptomatic patients may not require treatment. You always have to ask who lives with you. Are they also having the same symptoms? Because you should treat everybody so they're not becoming reinfected. I like to use things like mastigum, oil of oregano, berberine for the treatment of H. pylori. You also want to pay attention to the elastase level. In terms of H. pylori, if they're having a stomach ulcer, you're probably not going to want to add more betaine HCl to that. That will aggravate their symptoms. After you treat the H. pylori, it's also important to reduce stress and rebuild the gut mucosa, do some nice healing, such as a glutamine, to heal up the stomach and the small intestines. Here's an H. pylori case. This is a 35-year-old female. She had a past history of iron deficiency anemia, fatigue. She was using a PPI for 1 year for acid reflux, and it just wasn't helping. So we ran the GI map, and of course, her H. pylori came back high. Virulence factors showed BAB-A. Again, this is the virulence factors that promotes a lot of inflammation and long-term infection. So why this was a complex case for us was because the treatment, we needed to make sure our treatment plan was longer acting. So we actually had to treat this patient for 2 months. Most patients I'm treating for 2 weeks. This needed 2 months of treatment. So some of these complex cases, it's not that the treatment plan that was initiated first was wrong. It was just that it wasn't done long enough. So always keep that in mind. There has to be enough treatment to get the outcome that you're looking for. The way I treat H. pylori is based off of this study. This can be found for free access. Just have a Google of the name. It is a small study, but I have found a lot of success using this exact same protocol with my patients. I'm using mastigum, 500 milligrams 3 times a day. The Gastromen product contains the exact amount of mastigum that you need. I'm doing 2 caps TID. One thing you want to keep in mind when you're recommending a treatment plan to a patient is recommend, if you're using higher dosages than the bottle recommends, make sure to really emphasize that. I want you to use this dose that I'm recommending, not the dose in the bottle. In addition, when I'm using higher doses that's on the bottle, oftentimes the bottles are running out earlier than the treatment plan. So I tell patients you're going to need 2 bottles of this, 1 bottle of this. Also using emulsified oil of oregano, 1 tablet 3 times daily. Pepto-Bismol chewables. Bismuth is actually anti-H. pylori, so 4 to 6 of those a day. Make sure to warn your patients that that can cause your tongue to be darker and cause your stools to be black. If your patient Googles what black stools means and you haven't told them this, they're going to be quite upset. Typically in my practice, I'm looking at the full GI map, and I'm not always actually including a probiotic and fiber if it's not indicated based off of their GI map, but this research was using it. What they found was after a 2-week treatment, 74.3% of the patients converted to negative, suggesting that complete eradication of H. pylori. I typically do this treatment plan for 20 days because that's when 2 bottles of the Gastromen runs out. I have the patient come off and just reevaluate for symptoms. In addition, this research showed that all successfully treated patients showed improvements in their presenting symptoms of dyspepsia and irritable bowel type symptoms. So I have seen amazing success with this, and I'd recommend you check out the article. Normal bacteria. So in general, when you're looking at the normal bacteria, high levels result from reduced digestive capacity or constipation in general. Low levels are indicative of perhaps gut inflammation because a lot of these normal bacteria can't thrive in an inflamed environment. Autoimmune conditions, typically we see lower levels of normal bacteria, or they might result from lower fiber intake or reduced mucosal health, low beneficial bacteria. So you want to look at how is their diet, what is their past medical history of autoimmune conditions. This can really be important for helping you to choose the right probiotic. So if their lactobacillus and bifidobacterium levels are great, then perhaps you might not need a probiotic if all their normal bacteria is great. If their bifidobacterium is low, but their lactobacillus is great, maybe you just choose a bifido-only based probiotic. Normal bacteria Clostridia. Clostridia is a really important producer of short-chain fatty acids, so things like butyrate, which is important for maintaining a healthy gut barrier formation, immune modulations, and protects against pathogens. Because I'm dealing with a lot of metabolic syndrome, a lot of resistant weight loss, I'm always keeping an eye out for high Clostridia. High Clostridia is more likely to be linked to metabolic dysfunction. When there's low levels, again, we're likely to see inflammation because our normal good bacteria can't thrive in states of inflammation. Clostridia are major producers of beta-glucuronidase as well. We're going to talk about this towards the end of the presentation. But beta-glucuronidase can interfere with phase 2 detoxification involving glucuronidation. We're going to go more into that. So on the GI map, you see levels of beta-glucuronidase, and often we want to lower that to prevent the recycling of things like estrogen. But we want to know, why is the beta-glucuronidase high? Well, the beta-glucuronidase is high often because of too high of certain bacteria that are overproducing it. So in the case of many individuals with metabolic syndrome and estrogen dominant types conditions, you want to pay attention to Clostridia. Akkermansia muciniphila, this is another one I pay really close attention to because I treat a lot of weight loss resistance. This is a keynote species in the normal gut bacteria section. So if we go back and look at this report, what you'll see is Akkermansia muciniphila. Sometimes it'll be reported as less than DL, less than detectable limits, but it won't be flagged as red. It'll still be gray. A result that says less than detectable limits is not normal. It's very important to have some level of Akkermansia because lower levels are associated with metabolic dysfunction, so obesity, type 2 diabetes, hypertension, ulcerative colitis, and inflammation. When Akkermansia is too low, we see metabolic endotoxemia. When your gut microbiome cannot protect your body from absorbing toxins when you eat, this is a key factor in the development of obesity. Sometimes we do see an association with higher levels in patients with MS, but you're going to see higher levels often, right? So if you run a lot of this GI map, you'll see Akkermansia creeping up in a lot of individuals, and you'll not see that many cases of MS. So in terms of the higher levels of Akkermansia, what I typically see this more associated with is poor digestion. So you want to look out for H. pylori, low elastase, low steatocrit. Low elastase meaning you're not breaking down things like proteins, carbs, and fats well. High steatocrit is a marker of high fats in the stool. I also see high Akkermansia in low butyrate producing bacteria. So you want to look at how's their Clostridia, how's their Fecalibacterium Prausnitzkii. Gut inflammation and high calprotectin, you want to look out for that too. When I consulted with DSL, the company that makes the lab, They have recently thought that perhaps a higher cutoff of 1.0 to the power of 6 might be better for the Akkermansia levels than what it is set at now. And I would agree with that. Patient case. So here's a case with low Akkermansia. So typically low Akkermansia, I'm seeing this all the time in my weight loss resistance case, my type 2 diabetes cases, my insulin resistant cases. And this one was a little bit different. This one threw me for a loop because this was a patient who was very, very healthy, very active, did not consume alcohol. She was a vegetarian, lean body composition, feeling really good, but all she came in with was she had acute pancreatitis 2 times, idiopathic in the last 2 years, and none of the risk factors for it. She was interested to see, is there anything we can do to figure out why that happened? And I was kind of thinking, we're probably never going to know why that happened, but let's run the GIMAP test. She did have a family history of type 2 diabetes, so I wanted to check out the markers that would increase her risk for that, as well as her mom had Hashimoto's. So we ran the GIMAP, we ran her blood work. On her blood work, she did have elevated thyroid antibodies, but her TSH, T3, T4 were within its normal limits, so we're just going to monitor those antibodies. Her vitamin D was 114, her ferritin was 55. The key findings on her GIMAP, her H. pylori was fine, her opportunistic bacteria were fine, her Yersinia was fine. I was looking at Yersinia and H. pylori and opportunistic bacteria to see, okay, are any of those potentially increasing those thyroid antibodies, because there is some association there. No, everything looked good, but her Akkermansia was low. So I thought, okay, let's do some research on low levels of Akkermansia and pancreatitis and see if we can find anything. There were a few studies that showed an association with Akkermansia mucinophila and the pancreas, but what I found even more interesting was that mice treated with pancreatic enzyme therapy had a significant 58-fold increase in Akkermansia mucinophila. So I thought, okay, how easy is that to increase pancreatic enzyme support in this patient to increase her Akkermansia? Doing additional research, what I found was, even though the pancreas does not possess its own microbiota, what we have seen based off of the available research is that alterations in the gut microbiome can determine bacterial translocation. And there is a correlation with the prognosis of pancreatic disorders, including pancreatitis, diabetes, and cancer, which I found really, really interesting. So is the low Akkermansia, is bumping that up going to prevent her from having acute idiopathic pancreatitis? I don't know, and we probably won't know that. But I found this complex case very interesting because it led to this research. If you're looking at chronic pancreatitis, you want to make sure that you're having a look at the Firmicutes bacteroides ratio. If you're looking at type 1 diabetes, look at how the gut microbiome, the changes that we see associated with that. Metabolic syndrome, pancreatic cancer. So all things to keep in mind in patients that are coming with any of these pancreatic conditions. So even though we would say, you know, the pancreas is not obviously in the gut, and you know, what does the pancreas have to do with the gut microbiome? Well, here it actually has a lot to do with that, especially H. pylori. So I found that very interesting. Treatment for low Akkermansia, of course, we talked about the pancreatic enzymes. Reducing inflammation is really key. Other things that have been shown to boost Akkermansia are berberine. Also, metformin has been shown to support Akkermansia. So some of the beneficial impacts that metformin is having on the blood sugar might actually be from some of its impacts on the gut microbiome, which I think is very fascinating. Omega-3s, polyphenols, intermittent fasting can increase Akkermansia, weight loss, and caloric restriction as well. You can also consider some of the prebiotics to increase Akkermansia. I also wanted to touch on another keynote species, Fecalibacterium prausnitzkii. This is a major short-chain fatty acid producer. So if you're seeing low levels of this, you might want to consider bumping this up or supplementing with butyrate, because that's really key in the health of the gut mucosa. Prominent role in the gut ecosystems, it helps to reinforce the intestinal barrier function. So if you're seeing zonulin levels increased or intestinal hyperpermeability, you might want to have a look at this one as well. It can reduce inflammation and really help with immune homeostasis. So any of your patients that have irritable bowel disease, you really want to pay attention to this one, because low levels have been associated with IBD, diabetes, autoimmune conditions, colorectal cancer. Treatment, always address inflammation. So this is another one that falls into the normal bacteria category. So a lot of these normal bacteria do not thrive in states of inflammation. You want to consider prebiotics, polyphenols to help reduce inflammation like quercetin, curcumin, resveratrol, berry extracts, as well as you can increase this bacteria by supplementing with bifidobacterium, because bifidobacterium produces acetate that this bacteria can use to convert to butyrate. So it's more of a cross-feeding mechanism. Okay, next I really want to zone in on the Firmicutes-Bacteroides ratio. So what is this? Certain bacteria based off of how they look will fall into the Firmicutes category. Certain bacteria based off of the way they look will fall into the Bacteroides category. The same way we classify dogs or cats into one category and all the different species of dog and cat fall into that category. Same way as classifying animals, we're classifying the bacteria. Now they discovered this important ratio through twin studies. They took an obese twin, this middle picture here, took an obese twin and a lean twin, genetically identical. They took the gut microbiome from the obese twin, transferred it into recipient mice. Lean twin, gut microbiome, transferred it into a recipient mouse. Then what they did is they controlled for the diet, controlled for the exercise of these mice, and what they found was the recipient mice that got the obese twins' gut microbiome became obese. Same with the lean microbiota, made the rat stay lean. And this was really interesting because they looked at, okay, what was the major difference in the gut microbiome? And what they found was in the twin that was obese, there was an elevation in the Firmicutes-Bacteroides ratio. So this is something you can pay attention to in patients who have metabolic syndrome. And what they found was the higher this ratio, there was increased caloric extraction from the food that they ate, fat deposition and lipogenesis, impaired insulin sensitivity, so your insulin resistance patients, PCOS patients, and increased inflammation. Here's a case. This was an individual who was 45-year-old female, at least 60 pounds overweight, resistant weight loss. She had tried everything, Weight Watchers, keto, typically would lose 5 pounds and gain it all back, if not more, and she was very fatigued. So we did an initial blood work. We ran the hemoglobin A1C, which is the average blood sugar of the patient over the last 3 months. This, of course, was normal. So if you only looked at hemoglobin A1C, this patient would be considered normal. But of course, we do a more thorough investigation. We looked at her fasting insulin, and this was really high. So her body was having to work really, really hard to keep her blood sugar normal. And this elevation in insulin really makes it difficult for individuals to lose weight. So what we did is we also ran a GI map to see if any of that insulin resistance was coming from the gut. And what we found was, even though this ratio is not above 1, this is much higher than I would like it. So the Firmicutes is high there and the Bacteroides is low. So we definitely have an opportunity to improve this ratio. We did a higher protein, lower carb nutrition plan. She did intermittent fasting with 2 meals a day, 100% whole foods, so nothing processed, nothing from a package. We also added 800 milligrams twice a day of berberine, as well as a particular fiber that I really like called propylamanin. And we used a very specific only bifido strain, because remember, bifidobacterium will help to lower this ratio. What you don't want to do is use a lactobacillus-based probiotic, because a lactobacillus probiotic falls into the Firmicutes category. So we don't want to raise Firmicutes more. We want to use a bifidobacterium to raise the Bacteroides category and thus lower that ratio. We also use curcumin, and the reason we use curcumin is because we wanted to improve and reduce inflammation in the gut, because if you reduce inflammation, then the good guys can grow more, and of course some magnesium. So this individual had lost 20 pounds. We improved her fasting insulin. So her fasting insulin went from 203 to 123 now. But this time we actually ran a 2-hour oral glucose insulin challenge test, where we had the patient consume 75 grams of glucose in the sugar drink. And then we measured their insulin and their glucose at the half an hour, 1 hour, and 2 hour mark. And what you can see here is her insulin at the half an hour mark, already at 676, 1 hour, 949, and 2 hours, it is still going up. At that 2 hour mark, it really should be back down to the 250 range, and it should never at any point in time go over 500. So this individual, as much as we've made some improvements, she's lost 20 20 pounds, which is fantastic, she's still insulin resistant. So what we did is the patient decided that she wanted to switch up the treatment plan, and we wanted to add on Saxenda. And we did this to further improve the insulin resistance that she was experiencing. Here's again what you want to do if the FB ratio is high. You really want to emphasize only using Bifidobacterium, or Saccharomyces boulardii would be quite appropriate. You want to make sure that you're not adding too much lactobacillus or bacillus on as a probiotic, because that can elevate Firmicutes. You also want to look at diet. So high fat diet can raise this ratio, as well as high alcohol consumption. And I'm not talking about high healthy fats. So this is a diet more high processed fast foods, deep fried foods. That's what you really want to be looking out for. In addition, you want to look at, is there fat present in the stool? What is their steatocrit levels like? Because if you're not digesting and absorbing your fats well, that can change this ratio too. So it's important that you consume the healthy fats, but also that you digest and absorb them all and they're not hanging around in the stool. Additional support for a high FB ratio. Again, I talked about adding berberine on. I absolutely love berberine. I use it a lot in my practice. And the same way that we're seeing metformin, some of the impacts and the improvements of the blood sugar is actually due to the impacts that it has on the gut microbiome. We're seeing that as well in the changes in the gut microbiome with berberine. So we're seeing that berberine can help to alleviate inflammation, metabolic endotoxemia, by reducing exogenous antigen load in the host by elevating short chain fatty acids in the intestines. So really, really love berberine. I think it's a fantastic herb. Opportunistic bacteria. So these are bacteria that, given the right opportunity, can overgrow. I'm going to go through this section fairly quickly because we do have some amazing speakers on this conference who are really zoning in on small intestinal bacterial overgrowth. In general, when we see opportunistic bacteria, we are seeing that as a result of poor digestion, could be pointing to small intestinal bacterial overgrowth, as well as constipation or PPI use, poor stomach acid. One of the things we really want to identify is what gave these bacteria an opportunity to overgrow. And I think this is important to ask why this happened and try to figure this out, because oftentimes when we're treating these opportunistic bacteria, they have a higher likelihood than other things to come back. And that can be frustrating for the patient. So look at, are they chewing their foods? Are they taking time to eat slowly? What is their stress levels like? What is their sleep like? What is their antibiotic use like? How is their immune system in their gut? Can you support all of that first so that when you treat this, it's less likely to come back? I wanted to make a quick note about the Morganellas. This can produce higher histamine as well as higher levels of inflammation. So if you're having a patient that seems to have a histamine intolerance or is reacting to those higher histamine foods, check out if Morganella is there. Pseudomonas is one that can create inflammation, and antibiotic resistance can develop really quickly. So if somebody has a past history of a lot of antibiotic use, you could see that Pseudomonas higher. Again, ask what allowed the opportunity for them to overgrow, and you want to always look at the immune system, modify the nutrition plan, as well as consider broad spectrum antimicrobials in these cases. Here's an example treatment. This is 3 bullet points for 3 separate treatments that are often used, rotating in my practice. So we're either using a broad spectrum like a GI Microbax at a higher dose, oil of oregano. There's some research on the Methanogens product, Candibactin AR, Candibactin BR, as well as the pharmaceutical treatment. This is what we're using in our practice, Flagyl and Rifaximin. Methanobacter bacteria, this is one category that I look out a lot for individuals who are more prone to constipation. So these are more of the methane producers. They promote carbohydrate fermentation and short chain fatty acid production. So they are important. We don't want really low levels, because low levels could suggest inflammation, but we also don't want high levels, because a lot of individuals with high levels have that chronic constipation. So not all constipation cases do we just need to add fiber. Do they just need to drink more water? Do they just need to take more magnesium citrate? For a lot of these chronic constipation cases, it could be an elevation in these methanogens, and oftentimes treating them can be quite helpful. So consider in your chronic constipation cases, testing the gut microbiome and having a look if these methane producers are higher. Methane producers, here's an article that they showed that methane gas produced by the gut bacteria was able to slow the intestinal transit time by 59%, which is a lot. High levels, you really want to look at things like garlic, monolaurin, different broad spectrum antimicrobials could be helpful. Low levels, you really want to look at, is there lots of inflammation? Is there extreme dieting? Are they really, really low carb? Potential autoimmune triggers. This is a section that I really like on the GI map as well. So certain bacteria in the genetically susceptible individual can trigger an autoimmune condition. There are some bacteria, and this is not causation, this is correlation, but higher levels of certain bacteria have been associated with certain autoimmune conditions. Now, the thing to keep in mind with the GI map is you want to see all of these less than detectable limits, except for some levels of Prevotella as long as it's below the reference range, and some level of Fusobacterium as long as it's below the reference range is normal. Some levels of Citrobacter is not normal. Some levels of Proteus is not normal. The only ones you can see some levels with is Prevotella and Fusobacterium, so keep that in mind. Here's the associated autoimmune condition list: Citrobacter, rheumatoid arthritis; Proteus, rheumatoid arthritis. If individuals you're seeing higher levels of Proteus on the GI map and they have a family history of rheumatoid arthritis, you might want to consider treating that and also do a urinalysis with culture to see if Proteus is present there too. Yersinia is one I've added that's associated with autoimmune thyroid conditions, both Graves and Hashimoto's. Fusobacterium, that's the one at the very bottom. This one I pay a lot of attention to because it does play a role in biofilm formation. So if you see high levels of Fusobacterium, you might want to consider doing something for biofilm first. Fusobacterium species have also been associated with inflammation. So oftentimes with higher levels of this one, you see lower levels of normal bacteria. In addition, when you're treating Fusobacterium, you're more likely to see higher die-off symptoms. This is a common commensal, so one that's okay, normal to see, in the upper GI tract and the mouth, the oral cavity. But it also may colonize the lower GI tract. When we see higher levels of this bacterium in particular, and there's a decent amount of research on this one, we see more inflammatory conditions, so more IBS, colorectal cancer, systemic sclerosis, and this is one that I really like to treat with a good dose of antimicrobials. Fusobacterium has been associated with a variety of autoimmune conditions. In addition to this, what we're seeing is this is the most prevalent bacteria in periodontitis and may predispose to atherosclerosis. So we see in individuals with higher level of Fusobacterium significant atherosclerotic lesion progression compared with controls. So if you see higher levels of Fusobacterium, ask about their oral hygiene. How often are they going for a cleaning? In addition, we see more inflammatory mediators like IL-6, CRP, and higher levels of LDL, lower levels of HDL in these patients. So if you're seeing higher levels here, you might want to consider oral hygiene as well as cardiovascular health. Fusobacterium has been associated as well with type 2 diabetes, adverse pregnancy outcomes, so preterm labor. So if you're seeing this in a patient who is planning to get pregnant or is currently pregnant, definitely something to consider. Next section is the parasites. These are the parasites that are considered non-pathogenic, but do cause problems. And I see this in my practice in patients where they hang around too long. So not everybody, but typically I see in my patients treating these can make a big difference for them. One that we often see come up in functional medicine and naturopathic medicine is something called Blastocystis hominis. This one can be really tricky to eradicate. This is one that, again, like that H. pylori case we talked about, requires longer treatment. Dientamoeba fragilis, this is one that you can see skin rashes and hives. So have a look, ask your patient, are you getting rashes or hives? As well as they're often associated with co-infections with pinworms. So this is one that we more commonly see in kids. Wanted to talk a little bit of Blastocystis hominis because this really, I became aware of this one in one of my tricky histamine intolerance cases. We can see higher levels of Blastocystis hominis associated with histamine intolerance. And this is because it protects itself by disabling our nitrous oxide production. It does this by producing an enzyme called arginase, which helps to break down the amino acid arginine. And arginine is really important to make nitrous oxide. So without it, we actually have lower levels of nitric oxide. And this lack or this lowering of the nitric oxide has been proven to increase gut permeability as well as increase histamine, because nitric oxide is usually a mast cell stabilizer. So if you're seeing Blastocystis hominis and you're seeing a patient who's really struggling with higher histamine type foods, perhaps treating this may allow them to have more versatility and variety or reduction in the symptoms that they see. One thing that you want to consider supplementing with or testing for or considering is that Blastocystis hominis can perhaps lower magnesium. So magnesium levels were tested in 52 patients. Again, it was a smaller study, infected with Blastocystis hominis compared to 60 healthy controls. Those who had Blastocystis hominis showed clearly decreased magnesium levels versus those who did not. And what's interesting here is if you don't have enough magnesium, we can see a rise in histamine too. This is because low levels of magnesium impact those mast cells as well. So we really want to look at, if they're struggling with histamine, how can we help improve their symptoms, but also look at, okay, is Blastocystis hominis present? Do we need to help treat this infection? Do we need to bump up the magnesium as well in order to control some of their symptoms? In terms of therapeutic options, you can consider oil of oregano, pharmaceuticals, Saccharomyces boulardii, and the references for the studies about the magnesium as well as the therapeutic options are going to be right here, and you can have a look at these slides. Now we're going to get to one of the most important sections, is the intestinal health markers, to wrap up this presentation. Now, the intestinal health markers are important because they give us insights into why things were able to grow or kind of what's going on. Often I'm looking at this section first, so I'm getting a good idea of, okay, in general, what's going on in the digestive system, and then working my way back to try to figure out, okay, why is the inflammation high, or is, why is the beta glucuronidase high, etc. So this is what the intestinal health markers page looks like, and we're going to go through these one by one. So elastase is a marker of pancreatic exocrine function. So how well is the pancreas producing digestive enzymes to help break down proteins, carbs, and fats? Optimal levels are going to be greater than 500. You can see reduction in individuals who have H. pylori, individuals who have gallstones, as well as just as part of normal aging. Optimal levels is 500. So if they're not there, what you might want to consider is a digestive enzyme. You might want to also instruct your patient to really emphasize chewing your food, sitting down, relaxing at meal times, don't have electronics, kind of get in that rest and digest stage. The next marker is steatocrit. This is a marker of how much fat is present in the stool. So if that FB ratio is high and steatocrit is high, one of the things is you want to really look at how much fats are they consuming in their diet. Is it just too much for them to digest and absorb? And if not, perhaps they need a digestive enzyme, something with ox bile in it, to help them digest and absorb those fats. Sometimes we can see reductions in steatocrit in individuals who have issues with their gallbladder. People are not chewing, right? Sit, rest, relax, chew your foods. Don't eat on the go. Like, really, are you mindfully eating? Celiac disease as well, you want to consider that. Consider dysbiosis, consider SIBO. So these are all the things I'm thinking of when I'm reading the last page of the test first, then to go back and see if those things are present. Beta glucuronidase, this is a marker of phase 2 detoxification and how well that's going. If you have high levels of beta glucuronidase, this is showing interference with phase 2 detoxification. It's especially involving that glucuronidation step. So if your patient has estrogen dominance, this is something that you definitely want to have a look at. In addition, high levels of fecal beta glucuronidase can indicate unfavorable metabolic changes in the colon, so definitely something to follow up with. And then we have to consider, okay, beta glucuronidase is produced by bacteria. So you want to look at the major producers of this enzyme and see if they're high. So is the Clostridium classis high? Is the Bacteroides fragilis high? So here, your Streptococcus, your staph, these are the bacteria that overproduce that. If that's the case, then you really want to say, okay, we need to reduce this bacteria. Calcium diglucarate can help with phase 2 glucuronidation and phase 2 detoxification support. So that is on one hand helpful, but you also want to reduce the bacteria that is potentially overproducing these things. The reason this raccoon is here is because the way I explain this to patients is your liver is the one, like the organ that packages up things like estrogen and puts them in garbage bags, essentially. Then those garbage bags are put into the large intestine to be excreted. The garbage bag is the TAG, or the glucuronic acid. Now, if you live, in Ontario, North America, we have raccoons. Raccoons get into garbage, they rip it up, and they make a mess. So if you have too much of the wrong type of bacteria that's producing the beta-glucuronidase, you can think of those as the raccoons ripping up the garbage bags. Then the liver has to kind of go back and package them all back up again. And that's how I explain it to patients, at least so they can comprehend what's going on here. Fecal secretory IgA, this is the primary immunoglobulin in the intestinal mucosa. So this is like the first line of defense, the troops, the immune system. It plays a major role in helping to maintain the balance in the gut microbiome and protecting exposures to food-derived antigens. So right behind those intestinal cells that should be bound nice and tightly together, those tight junctions, sits the immune system. And we really want to consider the fecal secretory IgA. We really want to make sure that it's right in the middle, around 1,000, nice and balanced. So if it's overreactive, okay, have a look at the other patients. Why is it overreactive? If it's underreactive, okay, why is that? Are they chronically exercising? Are they chronically stressed? Do they need things like zinc and vitamin D? Colostrum can be helpful for raising secretory IgA, so can Saccharomyces. If it's high, you need to figure out why it's high. Is it high from an infection? Is it high from a food sensitivity? Check out the anti-gliadin IgA, which is a marker of gluten sensitivity. Is there dysbiosis? Find why it's high in order to reduce it. Anti-gliadin IgA is the next one. So this is a marker of gluten sensitivity. This is not a marker of celiac. Sometimes with high anti-gliadin IgA, I see patients with celiac when we test them. Other times I don't. Now, if a patient has anti-gliadin IgA that's high, what I tell them is you're not celiac, so it's not 100% for the rest of your life. You have to keep gluten out. But I do really like them to commit to a gluten-free diet. I start off by saying it's just 6 to 8 weeks. And then at 6 to 8 weeks, we can start slowly adding it in, potentially with a digestive enzyme that helps to break down gluten. But typically by the 6 to 8 week, they're feeling so much better. And I'm like, can we just take this to 12 weeks? And if we can take it to 12 weeks, then they're feeling 100% better. We give them the digestive enzyme when they're having gluten here and there. Calprotectin, this is a marker of irritable bowel disease. It's a marker of inflammation. So it's diagnostic for irritable bowel disease. So one of the things that you want to look at calprotectin, you can monitor IBD with calprotectin levels, but if these calprotectin levels are high, you definitely want to repeat it or refer to the appropriate individual to manage this condition. In addition, one of the things that you really want to emphasize to patients is you don't want to take a high dose of vitamin C and you don't want to take NSAIDs 48 hours prior to collection with the GIMAP because this can impact the calprotectin levels. It may indicate irritable bowel disease, polyps, diverticulitis, or colorectal cancer. So this is more of a red flag one that you really do want to consider watching or referring for. Zonulin, this is a marker of leaky gut or intestinal hyperpermeability. It's the proteins that opens the intercellular tight junctions in the gut lining. Zonulin and gluten. Now, if an individual is celiac, I think we all can agree that that individual should not consume gluten and do everything possible to keep cross-contamination away. Now, if an individual has higher levels of zonulin, what I'm recommending, regardless of their secretory IgA, regardless of their anti-gliadin IgA, is to remove gluten because there is an association between gluten and elevations in zonulin levels. So what I'm saying to patients is, again, the same story, 6 to 8 weeks. How are you feeling? You're feeling okay. You're feeling better. Okay, can we do it for another 4? The loss of these tight junctions can allow gliadin and other antigens to slip through the lamina propria here, go right between the cells. And this can trigger the immune system that sits right behind and create a pro-inflammatory response. And this can take a long time for this pro-inflammatory response to recover. So that's where it's a little bit tricky with these food sensitivities and this intestinal hyperpermeability. The patient's not going to feel better a day after completely eliminating it. And at the same time, they're not going to feel really bad if they put it back in the first day. So it has to be given enough time to see the beneficial impacts of removing it. Associations with elevated zonulin is celiac disease, but not always, non-celiac gluten sensitivity, irritable bowel disease, irritable bowel syndrome, type 1 diabetes, liver disease, MS. How to normalize zonulin levels, reduce gluten levels, add a digestive enzyme that'll help support the breakdown production of gluten if they have to absolutely have it, probiotics, fiber because it's going to increase the bacteria, and those bacteria can synthesize short-chain fatty acids, which is really important. You can consider things like zinc, vitamin A, glutamine. Glutamine is particularly helpful, especially in those high-stressed individuals. Even a good 5-10 grams of glutamine all at once can be really helpful for food cravings, especially stress-induced food cravings. So I'll have my patients, 5 to 10 grams of glutamine, some lemon, and a big glass of water, and even add some chia seeds to that. Give it a good 10 minutes. Oftentimes that's really helpful. And then, of course, looking at overall healthy diet. Do you have enough omega-3s in your diet? Do you have enough anti-inflammatory foods? Do you have vitamin C? And if not, perhaps consider supplementing with those things or supplementing with a fish oil. Before we wrap up here, one of the questions I often get asked is it necessary to use a biofilm disruptor or something to break down biofilm for a couple weeks prior to doing the GIMAP test, like proteolytic enzymes or NAC? And I've asked this question to Diagnostic Solutions Lab, and I personally don't use a biofilm disruptor either because this test is so sensitive. It's really not necessary to do it. It's really not going to increase the detection rate that much, but some practitioners do it and they like to do it, and it's really personal preference. So if you want to use a biofilm disruptor, great, go for it. So I hope you guys enjoyed that presentation. I wanted to tell you about the GIMAP training course. The link is here. This is the course that I mentioned earlier on in the presentation that will take you line item by line item of the GIMAP test. What does this bacteria mean? What does it do? How can you treat it with diet, lifestyle supplementation, or perhaps pharmaceuticals in some cases? So this is a really great course for practitioners who want to learn more about the GIMAP test, how to utilize it in their practice, how to develop treatment strategies for it, and how to properly explain the test to patients. If you are a patient or a client watching this presentation, this course can also be for you as well. A lot of my patients really like to understand what their results mean, and they love understanding what's going on in their body. So this could be something for you to consider too. Thank you so much for listening to the presentation. I hope you enjoyed it, and we'll talk soon.
Thank you so much, Dr. Breanne. There's so much information there and so many clinical pearls that practitioners can take away and run with to apply to their own practice. And as you can see, and as you've shared, is that there's so many applications to this. So it's not for someone who just comes in with diarrhea and constipation, whether they have diabetes, weight issues, cholesterol issues, you really do need to look at the gut health. So I see that you have a course here to help with practitioners understand this deeper, and we know it is a very expensive test. So why don't you tell us how we can learn more from you and how we can really integrate this into our own practice?
Yeah, thanks so much for having me on this conference and summit. I put together the GIMAP practitioner training course, and I know it says the practitioner training course, but I do have a lot of my patients and my clients take this course because it's really important from a compliancy standpoint to understand what's going on in your body. That improves patient experience, that improves patient outcomes. So in this course, I go line by line what each section means in more detail, things to look out for, as well as possible treatment considerations. So this is something that practitioners can utilize to go through and learn about the test. There's tons of case studies in there as well, or patients or clients who are interested in learning more about how to read their own GIMAP. This would be a fantastic resource as well.
That's so helpful. Thank you so much for all the time that you've put into your research and helping us practitioners just really grow our practices and help patients ultimately. So thanks again for being here. I really appreciate it.